Good morning, everyone. Welcome to our presentation here on our approach to addressing health concerns within female runners. I'm Dr. Adam Tenforde, Director of Running Medicine at Mass General Brigham Sports Medicine. I'm joined by an esteemed panel. We're going to hear from experts in nutrition, physical therapy, sports psychology, orthopedic surgery, and then launch into a case-based discussion on the multidisciplinary care that our female athletes deserve. With that, I will turn it over to Jessica Rogers, who will present on a sports nutrition topic.
Because as we see here, as low energy availability becomes problematic, we see things like reduced skeletal muscle function, impaired bone health. So if not, I'm looking at, are there risk factors for REDS? Where's the runner in the rehabilitation process, and what are the behaviors that they're currently doing in terms of diet, exercise, lifestyle? And then what are the behaviors that led up to the injury, and how can we change behavior and knowledge to optimize nutrition and prevent future injury? And so I'm really thinking about energy availability and assessing this throughout. So whether there are risk factors or REDS, for REDS or not, I start by evaluating their energy availability. Big picture, is the athlete taking in enough calories for their training load given their body? And so in general, throughout my assessment, I'm looking at some of these moderating factors. Are they on any medications that could be curbing their appetite and impacting energy intake? Do they have any GI issues like celiac disease or food allergies that are impacting the types of foods that they're eating? What is their sleep and stress levels like that could be impacting appetite? So to assess energy intake, I'm looking at this part of the equation, and I'm really looking at what their average intake is right now, how has it changed since their injury, and I'm looking at different windows of time leading up to their injury. So this is an example of a female adolescent runner that I had come to me to optimize her race day nutrition. And as we were going through it, I realized there was no appetite before the race. Appetite was super curbed after the race. And while she's having a really big dinner, she's never catching up on her calorie intake for the day. And so, 1 in 7 days for these female adolescent runners, she's getting about 60 to 70% of her energy needs. So it makes me curious about other windows of time that could be impacting her appetite, like before and after practice, that could be impacting her energy availability status and risk for injury. So I'm also looking at some of these red flags throughout my assessment. So I hear things like, I don't eat processed foods or I eat clean. I want to know more about the beliefs behind these statements and if it's having an impact on getting enough nutrition. And then I'm also looking at their knowledge while I'm evaluating what they're taking in. So does the athlete understand how to fuel appropriate for their training load? Do they understand the amount of carbohydrates needed to support their running volume? And then I'm also looking at this piece of the equation. I'm looking at, their exercise energy expenditure via like their training schedule. So what are they doing now? And then also what were they doing leading up to the injury? Most runners have, a Garmin watch or some type of activity tracker. And if it's appropriate, we'll kind of look at what an average run looks like for 60 minutes because it's going to take into account heart rate and be a more accurate estimation of what they're expending for their runs. And I'll factor that into the equation. The hardest piece really is estimating this piece of the equation, fat-free mass. And typically most athletes don't have this piece of information. So I use estimates of low, medium, and high fat-free mass estimates to like behind the scenes to see what range they need to be. And just, I'm never really talking about calories. I'm always talking about, servings of food, how to optimize nutrition, but these are the things that I'm looking at to prevent low energy availability behind the scenes. So 60, it's been estimated about 60% of female endurance runners, struggle with low energy availability. And then there's been, some research to show that this drive for thinness, or like thinner is faster, can have a great impact on their energy availability and their intake. And then, a lot of the work is changing beliefs to fed is faster. And adult female runners, there's been a lot of research to show that they're more cautious about increasing calorie intake and carbohydrate intake. So some of the work is beliefs and then knowledge as well. We often see that female runners, displace a lot of their calories with fiber because they're following the general recommendations of the population. And in adolescent females, they're far below typically the recommendation of carbohydrate intake, ranging below this 5 grams per kilogram, but they have increased needs due to the state of growth and development. And then other things I'm looking at throughout are their vitamin D status, their calcium intake, their iron optimization to, prevent bone mineral density issues long term and injury long term. And so that is all I have for right now.
We're going to turn this over now to Dr. Kerri Graber.
Are you able to see my slides okay? Okay, thank you. So hi everyone, my name is Kerri Graber. I'm a physical therapist with a specialty in orthopedics and sports rehabilitation. Today I'll be presenting on rehab considerations for the injured runner. So based on current research, there's a number of factors to consider when working with the running population. Running-related injuries are multifactorial, which is why we're all here today. Overall, it's important that we treat the runner as a whole, understanding that interplay between training, biomechanics, fueling, recovery, and psychosocial factors. It's important to understand that risk factors could be both internal and external to the runner, and it's important to further understand what is and what is not modifiable. And both the subjective and objective exam can help us determine what is modifiable and what we should focus on, as well as the need for more of a multidisciplinary approach to care. From a musculoskeletal perspective, ensuring adequate joint mobility, strength, single leg stability, and motor control are important key things to help limit compensations and non-optimal loading patterns. It's also important for us to evaluate running technique. This is very helpful to better understand the biomechanical demands that are more unique to our specific runner in front of us, giving us an idea of loading patterns, joint and muscle demand, and possible risk factors for injury. Just want to highlight some key discussion points from a subjective perspective here. I like to understand when their symptoms occurred in their training period and what continues to provoke their symptoms. What does their running history look like? Their training routine? Do they have a specific structure in place? What's their injury history? And as with all of our patients, it's important to screen for red and yellow flags. This helps us better understand if there's a more immediate need for a multidisciplinary approach to care. When it comes to the objective exam, most of us here are familiar with the musculoskeletal components. We want to ensure adequate joint mobility for the task of running. We also want to ensure adequate strength. Listed here are some muscle groups that I often look at and what's been studied in research and literature. We want to make sure that our strength testing is objective, reliable, and valid. So the way that we test is very important. Manual muscle testing these days we know isn't super great, so we want to make sure we have something that's reliable. Isokinetics testing is technically gold standard, but pretty costly and not available in most clinic spaces. In my clinic, we use handheld dynamometry and inline dynamometry to capture isometric data. That's been researched and validated. We often look at symmetry of strength as well as what the force output itself is. And then we often like to normalize that force output for the runner in front of us. We normalize the force output looking at something called torque to body weight ratio. And that allows us to better understand if the runner has sufficient strength to handle the task of running based on their own body weight and leg length. And we have some normative data to compare to for that. And overall, the goal is to limit compensations and promote good load tolerance. Considering single leg motor control, we like to look at a runner's general movement patterns to better understand their own loading patterns and injury risk factors. We often look at slower movements first, like single leg stance, single leg squat, followed by more faster and dynamic movements like jumps and running. Considering the running assessment itself, listed here are some key features that we look at. And it's important to assess running technique itself because we can see kinematics that are more specific to the task of running. You might not capture that with single leg stance, squatting, or jumping alone. It also allows you to capture additional variables like foot strike pattern and cadence, altogether providing some more insight into those specific biomechanical demands unique to the runner. Unfortunately, there's limited high-quality prospective studies exploring the relationship between running-related injury incidents and running biomechanics. I've listed some things here that I've found to be highly associated with running injuries, like hip mechanics, ankle-foot mechanics, and ground reaction forces. We have much better evidence investigating the impact of running technique on kinetics. And this is nice because this allows us to better understand how we can modify stress and load to an area where a runner might have recurrent injury. And lastly here, I just want to touch on sex differences. There's a similar approach to rehab from both a subjective and objective standpoint, but understanding key differences in injury risk allows for a bit more tailored rehab. Concerning specific injuries, we know that females have a higher incidence of bone stress injury, patellofemoral pain syndrome, IT band syndrome, and hip and groin injuries, and males have a higher incidence of Achilles tendinopathy. From a biomechanical standpoint, we know female runners have been shown to demonstrate greater hip flexion, adduction, and internal rotation angles during running. And we know that these are movement patterns that have been associated with specific injuries that females are at higher risk for. And it's important to understand that these movement patterns have both modifiable and non-modifiable contributors. Anatomical differences are thought to contribute as females have a wider pelvis and Q angle. And this is something that's important to consider because this is non-modifiable. So I likely won't be able to correct these movement patterns entirely within female runners, but lower extremity strength and motor control are additional factors that are modifiable that can influence the extent of these movement patterns. And even a few degrees less of hip adduction and internal rotation can reduce joint and soft tissue stress. Additionally, lower extremity strength in general can improve tissue tolerance to loading. So there are things that we can look at from a modifiable perspective. So with my female athletes in particular, I'm sure to include even more hip and quadricep strengthening alongside motor control training. I may also be more likely to consider gait retraining in this population to try to reduce biomechanical risk, especially if it's a runner who has a bit of a greater Q angle. I also have a much lower threshold for suspicion of bone stress injuries in this population. If a female runner even has a couple of risk factors present and symptoms aren't super consistent with another diagnosis, I'm much faster to refer to orthopedics for imaging and further workup if they haven't seen someone yet. And thank you.
Great. So next we're going to hear from Dr. Kendra Becker, who's going to talk about mental health and sports psychology within the female athlete.
All right, thank you. Can everyone see my slides okay? Yes, hopefully. Weird. Okay. Yes? No? Okay, I don't know what's going on. I'm sorry. I'll try that again. Still nothing. Can you see my screen at all? Weird. Okay. What about now? Okay. Woohoo. All right. Sorry about that, everyone. All right. So I'm delighted to be here with you all talking about just psychology of running, some factors that are important for runners, and then how that may impact injury and injury recovery. So thank you for having me. really quickly, I think it's just important to think about some of the psychology that is relevant for running general. Um, Often we think of running as being a mental sport. And what I mean by that is there's a lot of research showing that people kind of think they need to quit well before their muscle capacity or their body needs to quit. So it's really the brain that's helping folks determine when they're done, when they're ready to finish a run or a race. So what a lot of training involves is helping the mind train to push past body signals or perceived limits and learning to tolerate discomfort that may be present during running. It also, like, it's the mind that we're training to encourage consistency with training and showing up even when you don't want to. So why is that important to review? It's important because it starts to develop what we might think of as mental toughness for runners. And what that means is this mindset that's characterized by high motivation, confidence, focus, self-discipline, and determination. And these are all really important qualities to sticking with this sport. It's part of the sport. It's part what, kind of develops people into like good runners, being able to dig deep, push past that tiredness at the end of a race to finish strong. So this is an important mindset that we want to cultivate for runners, and it is this dialectic where folks can kind of over rely on this mental state, and can kind of leave them vulnerable to potentially problematic beliefs. So it's both a greatest strength and potentially a weakness for some runners. So beliefs that could be problematic that are tied to this mental toughness state could be this idea that continuing to exercise or pushing harder, training more is always better, and that they can optimize their performance by changing their eating patterns, maybe without the consult of a dietitian. So this may be folks thinking, again, we've already heard mention of eating clean or kind of eating to improve performance, which sometimes, especially for female runners, can include this idea that thinner is faster. It can also be underlying some thinking that all pain is something that one can push through. So this idea of like no pain, no gain, and kind of just an overarching theme that like pain is something that can be tolerated as well. And finally, a tendency to perhaps overvalue the athletic identity. Now, what this means is not that they don't enjoy just being a good runner. It's more than that. It's this idea that their performance and their pace, their mileage, et cetera, starts to determine their self-worth. So these are kind of the risk factors that this mindset can lead to. And because of that mindset, we may see vulnerabilities in certain areas. One may be not paying attention to pain that is problematic or indicating that there could be a more serious issue that could be treated easily early on, but maybe missed because of this no pain, no gain, push harder mindset. I think this can be really common in our runners who aren't necessarily part of a team or are professionals, folks who are like amateur kind of runners who are like our weekend warriors, that type of thing. They can increase mileage too quickly, and they may not notice that they might be causing some potential weaknesses that could turn into problematic injuries down the road. Another topic we've heard a lot about today already is this idea of low energy availability. And that can come from this belief because folks trying again to think about how to optimize their performance, cutting foods out, thinking that certain foods are really relevant to their performance, and not necessarily being aware of what their body needs in order to perform well. So it could leave folks vulnerable to not getting enough nutrition, especially for the level of output that they're producing. And finally, this mindset can kind of underline like misunderstanding overtraining syndrome. So folks may use running to manage a lot of the symptoms of overtraining symptom like depression, low motivation, anxiety, kind of just fatigue, which of course, if it is overtraining syndrome, then they're kind of just digging themselves in deeper. So we already know what relative energy deficiency syndrome is, so I won't harp on it too much longer, except to just highlight that some of the real key point here for female athletes is the low energy availability leading to compromised bone and menstrual function. And the reason that's important psychologically is that if someone has like poor bone density or loss of microstructure of their bones, as well as muscle deficiency, they're at increased risk for injuries because of being at increased risk for injuries, then there's increased risk for depression and anxiety. And potentially, if they have these complications, that's going to also influence their recovery period. In addition, reduced estrogen not only impacts bone, but also impacts brain health. Estrogen is a neuroprotective hormone. It is involved in being able to think, plan, manage mood, etc. So without this hormone, people are more at risk for less flexible thinking, so being more rigid thinkers, having more difficulty with anxiety and depression, becoming really compulsive, and having worry about this idea of weight, shape, and eating. So keeping all of that in mind, when someone is injured and they are a runner, we've already talked about how that can be really relevant to their identity as a person. But that also is probably, given how much time they might be spending in this activity, how much value they place on themselves being a runner, that a lot of their community and social connections can be wrapped up in running, which means if they are injured and taken out of that community, there's not just grief and depression associated with not being able to run as part of like how they see themselves as a person, but also not having social connections, really feeling isolated and left out. And then running may have become a primary coping mechanism for some individuals. So not being able to use that means they've got a lot of big emotions for a lot of reasons and having no real way to manage them. And so what you can see is folks who have a lot of difficulty with rest are really itching to get back to running and may do things like be pushing their recovering too quickly, or may not be able to stick to recommended levels of activity during the recovery process. So really, treatment, the way that we've thought about it, is it must be multidisciplinary for runners who are injured. And that includes really collaborating with sports physicians, PTs, especially dietitians, surgeons, if that's been necessary for someone, and include working with those teams to really educate about overtraining, sleep, REDS, injury recovery processes, and in doing so, help people kind of develop more mindfulness skills, so being able to listen to their body without judging it, being able to find a wise mind understanding of what is pain that is expected with their sport and kind of aging throughout their sport, and what is pain that indicates they need more support or should be looked into, refocusing attention on the present and kind of redefining with new activities, new identities, as opposed to just waiting for the recovery process to be over and being too forward thinking, including ways to manage emotions beyond activity and running in particular, expanding coping skills, interest, etc., that can help them build communities that are include the running community, but are broader than that, so that they have more of kind of a cushion even if injured. All right, so that's all I have for you today. Thanks so much for now.
Thank you. Finally, we're going to hear from Dr. Greg Waryasz, and then we are going to go through 3 cases together.
Get this thing loaded up. All right, everyone can see my slide? All right, perfect. We're going to be talking about surgical management of the athlete stress fracture, and then a little bit on tendon issues. The disclosures. So stress fractures are common in recreational competitive athletes, and it's due to repetitive submaximal loads, and so we see them all the time. So you have to get a good history on a patient. You ask about training, you ask about when they started having pain, and then you should always ask about male-female athlete triad, energy deficiency, reproductive suppression, and impaired bone health. So as an orthopedic surgeon, it's the most awkward conversation that I have, but I do that with all of my female athletes. So imaging, plain radiographs are oftentimes negative, and so you can repeat them in a few weeks, but typically we'll get MRIs on our higher level athletes. And MRIs really replace bone scans for me. Not all edema leads to stress fractures. There are these sort of bone stress syndromes that are present. And tibial stress reactions are found in asymptomatic college runners. So something to be mindful of. So push on the area. If they have pain, it's real. If not, then think about it. Low risk stress fractures, we don't really have to worry about surgery usually unless it's been persistent for greater than 3 months. Posterior medial tibial shaft, fibula, calc, cuneiforms, cuboid, metatarsal neck, and shaft. So the posterior medial tibial shaft, we get a lot of referrals for these. We use a Fredrickson classification, which is based on MRI. It's typically posterior medial pain versus with activity and tentative palpation. Usually we just treat it 4 to 8 weeks in a boot until the tenderness is resolved. With grade 1, you can actually get just around a 2-week return to sport. As you get middle grade, it could take around 40 days to go back to sport, and then grade 4Bs can be up to 71 days without any type of surgery needed. Fibula stress fractures, they're usually the distal third proximal to the syndesmosis, and people with flat foot oftentimes are more susceptible. We usually do weight bearing early in a boot, and they can get back to sports in 2 to 3 months. Every once in a while, one of these doesn't heal, and you have to either do a fibula nail or plate it, but typically they heal up. You just have to be mindful of if there's any shortening through the bone that can lead to arthritis in the ankle long term. Calcaneal stress fracture is also one that we typically don't have to treat surgically. It's usually due to repetitive heel strikes and non-cushion surfaces, and the Achilles probably is a big contributing factor. Oftentimes patients have other tarsal stress injuries or fractures. And the big thing on exam is a positive calc squeeze test. So every patient of mine that comes in for plantar fasciitis, for example, that's a positive calc squeeze test, will get a MRI to make sure it's actually just plantar fasciitis and not a stress fracture. And usually limit weight bearing, immobilize in a boot. You can advance, it's tolerated. Again, it's typically not surgical, and I've done very few operations on these. Typically, patients have symptoms more than 6 months. Cuneiforms and cuboids, they're uncommon. You have to consider neoplasm or tumors. I've seen one that was an osteoblastoma before, and it can get confused with sinus tarsi syndrome or proximal metatarsal stress fractures or coalitions. Usually, you just treat with 6 weeks in a boot, and they usually typically resolve. The MRI will take longer to resolve than other injuries. This was a Division I track athlete, 21-year-old female, who had this persistent cuboid pain, and so she had many years of pain, and so finally we went in for open reduction internal fixation and cleaning up a little cartilage flap, and we used the biointegrative nail to stabilize the cartilage surface underneath, and then I sort of make it look like a golf ball and drip in PRP or bone marrow aspirate typically on these. And the patient healed up. She was back to track, and she's been pain free. Actually, I have 2 years of follow up on her. Now, I talked to her last spring. Metatarsal shaft fractures are common in the second metatarsal. Fifth metatarsal shaft is not as common. The case that I have here is a Division III female track athlete that was treated non-operatively for this, and it just didn't heal. So we ended up doing a plantar staple and a plate to stabilize her because it was too distal for a screw. And she was back to sports in 3 months, all fully healed up. So occasionally you have to fix some of the low risk stress fractures. The high risk ones are the ones we talk about fixing more commonly. So that's your anterior tibial shaft, your medial mal, talus, navicular, and the bases of the metatarsals, hallux sesamoid. Anterior tibial shaft, repetitive jumping athletes. It's on the tension side of the tibia where there's poor blood flow, and you see this sort of dreaded black line, we call it. And this is a CT scan of it. And there's debate between operative and non-op. Non-op can delay return to play for 8 to 12 months, while surgery can shorten return to play to 4 to 6 months. The problem with nailing is you can get knee pain, but with plating, the plate can be very symptomatic, and oftentimes these will get this hypertrophic bone formation, and it's actually very hard to put the plates on the tibia in that location. But typically, I'll go to open plating for bilateral patients, which occasionally I'll see in the military population. This was a professional basketball player who had a dreaded black line. We ended up bone grafting the anterior cortex and then nailing. Was back to sport in 3 months. Talar stress fractures, they give you like vague ankle pain. It almost seems like ankle impingement, and then you'll find it on the MRI. Should do non-weight bearing until symptoms resolve, which is usually like 6 to 8 weeks. Orthotics with medial posts for flat foot patients and tailor head involvement can be present. And occasionally we'll drill it or use biointegrative fixation for refractory cases, usually greater than 3 months. Medial malleolar stress fracture is really the fracture pattern is an unstable vertical pattern, something we would call a supination adduction fracture. And once there's a fracture line, I will typically fix it. So edema you could try to treat non-operatively, but once there's a fracture line, either buttress plate or screws. The reason why I say it depends on sport. So for a runner, it doesn't make a huge difference, but if they also ski or ice skate, typically I'll try to use screws instead, so it doesn't bother them as much in footwear. Navicular stress fractures are abundance in our track and field athletes and cross country runners and marathoners. If they occur in the watershed area, the central third of the navicular, and we use a mall sexiness classification, which is CT based typically. Really, once it gets to stage 3, it's a different problem altogether, and it's actually very concerning for long-term arthritic problems. So we want to try to kind of keep it in that 2 range if possible and fix it. So this was a case of a patient that actually had a stress injury as well as a talonavicular osteochondral defect. So I did an open grafting with allograft cartilage and PRP, and then a little compression plate over the area. We try to be very mindful of the soft tissues on these. You can try to offload them for 6 weeks, and then if there's any displaced fracture, we fix, or sclerotic changes, meaning that it's a higher grade. You want to avoid devascularizing, respect the soft tissues, and either use bone graft or bone marrow aspirate. So with surgery, return to play is usually around 4 months. With non-op, it's around 21 weeks. I've seen some patients get back as quick as 6 to 8 weeks. This was a high school soccer player who came to me with this sort of lateral based navicular stress fracture, was fixed and back to sport, and in 6 to 8 weeks was able to resume play in season. Fifth metatarsal base fractures that are non-fifth, they usually lead to local swelling and tenderness. They almost present like midfoot arthritis. Non-union can be fixed. You're either doing a plating or a fusion, depending on the extent to the joint line. And more recently, for these ones that have been present for greater than 3 months, I've been drilling them percutaneously and then adding in bone marrow aspirate or adding in a biointegrative nail, which is magnesium polymer based to stabilize it. I've had good success with getting rid of symptoms early with that. Your proximal fifth metatarsals are common in runners. People often describe landing and then hearing a crack and not rolling, and then rolling the foot afterwards. So you're going to look for foot alignment, cavus, metaductus, and cutting sports. The TOR classification is more for research based, and it's usually try non-op for type 1s, which are acute, and then operative for athletes. The longer chronicity ones. The plantar gapping greater than 1 millimeter and higher grade torgs have longer healing time. So you got to be mindful of that when you see plantar gapping. And that's also the last part to heal. So a lot of times patients will be completely asymptomatic if you're seeing them at their therapy appointment, but they're not fully healed. And there's not really general consensus on how much needs to be healed for it to be considered healed. The hallux sesamoids are repetitive compressive loads. We see them often in high-level athletes. This was a Division I gymnast who was really pounding her lateral sesamoid, and we took it out because she had had a year of symptoms. And I typically prefer just to excise, but you can't excise both. You want to do just one, and then if you have to excise both, they can get a deformity, so you're trying to avoid that. A little thought into dorsiflexion osteotomy to offload, but most people aren't doing that. Treatment strategies, kind of medical management, calcium, vitamin D, bisphosphonates, PTH analogs. bone stim and shockwave, cast versus boot, and surgical treatment. So the best offense is a good defense. You want to prevent, good shoe wear, proper techniques, good dietary habits, new running shoes, and avoiding year-round sports in the pediatric population and cross-train. So takeaways, you want to ask about the male-female athlete triad. Don't miss a tumor. Consider early advanced imaging in athletes. Early surgery on higher risk fractures can lead to return to play quicker, and use adjuncts. Tendon differences, just quickly, with the Achilles tendon, actually females are protected more than males. Males have increased Achilles length, thickness, and cross-sectional area, which lead to higher loads and a higher injury risk. In this study of almost 6,500 runners, there was equal amounts of injuries between male and female participants, and there was no relevant sex differences in running related injuries, which was interesting to me. And that's it.
Well, thank you so much. As you've heard from our four speakers, there's a span of different options, but really the way we think about the treatment of these injuries is a multidisciplinary model. We're going to go into 3 cases now. These will be displayed in the chat, but the first I'm just going to review briefly. This is a 23-year-old female runner presenting with bilateral anterior knee pain. These symptoms are provoked with running, but also when performing squats or prolonged sitting. The pain's difficult to localize. It feels like it's more in the anterior knee. And prior treatments include a palpation-guided steroid injection and some initial physical therapy that was focused on the lateral hip and quad strengthening. So, cutting to the chase, what we're really describing is what's been described in sports medicine as one of the most vexing issues that we can face, given the challenges of chronic anterior knee pain. And oftentimes this fits into the pattern of patellofemoral pain syndrome. I'm going to start with Dr. Graber. Give us a little bit more thoughts in terms of what we might be able to add, such as gait evaluation and gait retraining for this condition.
Yeah, absolutely. Thank you. So with this type of runner, if we're thinking about gait retraining, and I'd also be curious about, we know that she's done a round of PT before. I'm curious if there's any motor control piece of that. So did they look at her motor control, single leg stance, squatting, jumping, and then taking it that step further to running? And if we're looking at running specifically, I want to know with this female runner in particular, do we see things like that increased hip adduction, internal rotation, knee valgus, like that type of pattern? And what does their foot strike pattern look like? And if this is someone who's had recurrent knee pain for pretty long and they've done a number of things to try to address their symptoms and nothing's helping, then gait retraining could definitely be something that we focus on. And that could be switching their foot strike pattern. If they're more of a rear foot strike pattern at their baseline, we could be trying to transition them to more of a midfoot or forefoot strike runner. And we could do that through cueing. And that could be just cueing them, okay, try not to land on your heel as much. It could even just be increasing their cadence a little bit. A 5 to 10% increase can even switch them a little bit further to that midfoot to forefoot. And both of which can help reduce that load to the patellofemoral joint. And there's also video cueing that some people will use if they have their runner on a treadmill and they can see themselves, like there's a video to the side of them, they can see how they're landing, a video in the front, they can see how they're landing. And sometimes having that visual feedback can be helpful for running retraining too. So giving them a variety of different cues can help them get to less of a rear foot strike pattern, possibly increase their cadence a little bit to help with not only their joint mechanics, but also the amount of load going through the knee joint.
Yeah, absolutely. Now, oftentimes this has gone beyond just a focus on improving strength, but also the way it affects the whole athlete. Dr. Becker, could you comment a little bit on what you observe, such as kinesiophobia or even the effects of chronic pain on mental health and how you address this?
Absolutely. Thanks for that. So I think I'll start with the chronic pain and just kind of what we try and do is help someone start to develop more of a narrative around pain. And what I mean by that is oftentimes people think they should be in no pain or it's excruciating. And so what we're trying to help people do is start to think of pain as a signal, start to think of pain as something that can help their providers help them, start to understand that there is some pain that signals that something is wrong, but also pain that could be something that's just natural and expected with high levels of activity. So we start having them stop thinking of pain as always bad and start to reframe their expectations around what pain is and what they're trying to get to with their team. And I think stop having it be kind of a catastrophic experience when they experience pain and really adopting more of a non-judgmental observation or mindful kind of understanding of it being a signal from their body and learning to listen to those and interpret those. So we do a lot of work around that and also really staying present focused, helping folks not think, like, what does this mean for my next season? Or what does this mean for my career as a runner? Really trying to stay present focused and stop bringing worries or concerns about what may the future hold. That makes it harder for them to do the work that they may need to do in the moment to recover well. I think if it's a fear of pain, especially if the pain is mild, we're doing exposures and helping them see again that they can tolerate certain levels of pain and that it doesn't always end up being a catastrophic signal that something is really wrong, that they need to stop or need to call their providers or need to schedule an emergency appointment. So it's kind of exposing them kind of in a hierarchical fashion. So gradually letting them see that they can do certain activities. And again, kind of balancing that dialectic of being aware when something is beyond that threshold and it is kind of an activity or a stressor that they need to then discuss with their team. So I think, broadly, the answer is helping people develop more nuanced understanding of their body and their pain signals, and then being able to start to kind of focus on the moment, not catastrophize, and be able to use their team wisely.
Yeah, absolutely. And that can be so helpful for so many of these athletes that we see in clinic. It's really devastating when your identity is being disrupted by an injury, and being able to reframe and be able to identify strategies to work with the team that we have in front of them. That leads me to you, Jessica Rogers. Can you comment just briefly on maybe some additional thoughts from a nutrition standpoint for recovery from injury or other considerations?
Sure, thank you for that. I think similarly to what Dr. Becker was saying, typically if runners have been having a hard time paying attention to pain cues, sometimes their hunger cues are not. They struggle with listening to those hunger cues because they've been avoiding some of the cues and start to mistrust the cues in their body. And so it's really about that paying attention to, if I'm hungry, am I eating, and whether their hunger cues are apparent or not. And so I'm evaluating the whole lens of the big picture. Are they getting enough? And then looking at some of the micronutrients as well, like iron status, calcium status, vitamin D. And then in this scenario, you could also consider collagen before exercise, before physical therapy. It's a class B recommendation, but if we haven't had, success in the past with rehabilitation, it's something you could consider if it's right and appropriate for this specific athlete.
Yeah, absolutely. And again, we have to recognize that sometimes, the mental health of the athlete can be impacted by these injuries that can change their eating behavior or even their goals to try to maintain some, quote unquote, ideal body weight during an injury. So we have to remind the athlete to maintain an anabolic state for recovery. And you can hear that Dr. Waryasz is not talking about doing a full lateral release. That has really fallen out of favor. We want to respect the anatomy, but we also want to recognize how do we stimulate the body healing. And I really enjoyed hearing in your talk the concept of thinking about a team-based approach where it's not necessarily just the surgery and just the fixation, but other kind of biological tools that can help the athlete to heal. I'm going to get into the next case here, and this is a 48-year-old female runner presenting with a multi-year history of heel pain localized to the Achilles tendon. These symptoms seem to be provoked running at faster speeds using super shoes, which are defined as this advanced footwear technology, oftentimes involving a carbon fiber plate, which can change foot strike pattern. And there's associated stiffness and a limp in the morning that improves with activity. There wasn't an episode of a pop or loss of strength to suggest a full tendon tear. However, these symptoms have continued, and there's a notable change in how this athlete has been feeling, noticing some symptoms consistent with entering menopause. And she's also endorsing that it feels like other joints seem to be a little more achy and it's taking a little more time to recover. She's quote unquote feels like she's falling apart. So, how do we put her back together? How do we get her motivated here? First off, Dr. Graber, what's our typical approach for the management non-surgically of these tendon injuries?
Thanks, Dr. Tenforde. So looking at this specific type of female runner, I mean, there's a couple of things I want to touch on here, but I think if we're talking about tendon injuries in general, I'm very curious what their training looks like in terms of like how they structure their training. Is there a lot of terrain? Are they running on different hills and different dirt surfaces? Are they cross training at all? How are their recovery blocks set up? Do they supplement their program with strength training? We know that with an aging runner, there are specific physiological changes. We know that there's decreased plantar flexor moments, decreased propulsive forces. The calf and like radius soleus complex through the tendon from physiological perspective has changed a lot. There's less stiffness, that tendon's a little bit less resilient. So making sure that they're doing some form of strength training can be very helpful to just improve tolerance to load, rate of force development, lower limb stiffness. We often, from a rehab perspective, incorporate isometrics to help with tendon pain, and that can be really helpful at the early stages. And then from there, building so they have greater resilience to load over time. So getting away from those isometrics, but introducing heavier load for that tendon. Alongside that, making sure that they have good hip strength too. Like we want to make sure, and good hip extension mobility. I mean, if they're able to get good propulsion from those hip muscles and just from that mobility itself, it can take some pressure off of that tendon. So thinking about it from different perspectives there is very helpful. And when we think about the shoe wear, I mean, if this is someone who's not used to running with a specific form that a carbon fiber plated shoe causes them to run with, like if they, it's putting a little bit increased load to that ankle foot complex. And if they didn't have a great transition period when using that shoe, they didn't slowly transition to that shoe wear. And if they have inadequate strength and control to withstand those new forces through the ankle foot, that can be a contributor as well. So there's a lot of different pieces to think about with this type of athlete.
Absolutely. And I'm going to go next to you, Dr. Becker. I think you made a really strong point that estradiol has effects throughout the female athlete. And these different changes with aging, as we refer to kind of the aging athlete, this is a really important consideration. Just to provide a little voice to this, we are starting to revisit the concepts around the use of transdermal estrogen to support orthopedic health at different stages. Of course, that has to be considered through a full medical workup to determine the appropriateness and risk stratification. But perhaps a little bit on your approach to taking care of the athlete that feels like her identity might be changing as she ages and helping to avoid some of those concerns.
Yeah, thank you for that. So I think a lot of times with these athletes, something that we have found really helpful in our program is starting to think about and kind of almost embrace a little bit of these changes, as opposed to trying to identify them as like thought distortions or problematic thinking. I think we want to identify that sometimes we can get stuck in a way of thinking that doesn't help recovery, like, oh, I'll never be the same or something. But I think really what we're trying to do is say, well, and that's okay, because like life is changing, you are changing. These are the things that now we have opportunities to do, and redefine, like, keeping that idea of like once an athlete, once a runner, always a runner. Like once when like this is part of your community, this is who you are, this is who you've always been. How do we engage with it differently? I think a big part of what we've been doing is starting to build a community. We have encouraging runners who are at various different stages of recovery through some of these types of injuries to come together, to start to like normalize the experience and kind of find support in each other, versus feeling they're siloed and isolated and alone in this, and that everyone else is able to do everything that they want to do, and they alone are kind of in this like isolated, pained experience. I'm starting to, really, really broaden that community and thinking about, we're not trying to replace running with different activities, but what are other ways in which someone can be connected, can find self-worth, can be active? And so that there's not so much pressure on needing to run at a certain amount or a certain time or a certain distance. And it's really more about kind of embracing kind of just a change in what their life might look like that still includes running, but is different, and that is okay. So I think we're really kind of moving towards that narrative of more of like a whole body acceptance that like things do change and that isn't necessarily bad. And really highlighting all the good changes that have come with a life well led and an active life.
Yeah, so not really avoiding the thought, but more embracing the changes and recognizing you can maintain that identity and community even through recovering from injury. Um, Jessica Rogers, I don't want to negate the importance of nutrition and diffusion on protein synthesis and recovery, but I do think this would be important to hear from Dr. Waryasz here for a moment. When do we consider surgery, or at least maybe the more minimally invasive approaches for treating a more chronic case of tendinopathy?
So I think it breaks down to two different types, right? So, and they're very different. So the insertional variety tends to have better treatments. And so we're actually about to publish a series of ultrasound debridement haggling resections, which have shown reasonable results, taking away like a millimeter or two of bone at the haggling site, particularly if there's not calcification in the tendon. The open Achilles debridement and reattachment surgery works well, but it's a lot harder to get back to sports. And then there's an endoscopic or minimally invasive burr option, which is newer, that patients actually can get back to running even in a 4 to 6 week period. And so the insertional is the one that I think actually has the better treatment options for us. The non-insertional is the one that we actually deal with a little bit more frequently because it's harder to treat, and that's that bulbous tendon. And so, aside from orthobiologics and shockwave therapy, and when that fails, an ultrasound guided debridement is an option, but it has a little more mixed results. And we get into these open surgeries, which don't necessarily lend themselves to getting back to pre-surgical activity levels. They oftentimes lead to pain relief, but people can't run and things like that because they can't push off the same way. The hope is that some of our new bioinductive grafts will be helpful for that. And so, there's a collagen patch one that I'll use from time to time, and then there's a variety of different synthetic types that might be helpful, but I'm trying to avoid surgery on those in people that are running, and it's better to figure out how to activity modify and sort of treat through the condition.
So we're going to go now into our third and final case. This is a 17-year-old female runner who is presenting for an additional opinion due to recurrent overuse injuries to bone, which can include a stress fracture. She has recently experienced a right tibial stress fracture 4 months after recovering from a left sacral ala stress fracture. Her age of menarche was 15, which we believe to be now delayed since women are tending to have periods at younger ages in the US. She's reporting her periods are normal, although she's now on oral contraceptive pills that were prescribed to regulate her periods. She doesn't feel that she's intentionally trying to lose weight or has a history of an eating disorder, but really is, a busy, active young lady who doesn't really get to breakfast a lot of times because she's rolling out of bed and getting ready for class, and has been experiencing some fatigue that's been associated with iron deficiency. So really, this case highlights, a challenge that our team faces. Dr. Waryasz has outlined some of the surgical options, and we hope to not have an injury progress on to requiring that type of internal fixation. But really, what we're hitting here are a number of key themes of identifying the young athlete that isn't quite at peak bone mass accrual, which occurs at age 20, is been prescribed oral contraceptive pills to try to regulate periods, which we look at as the female athlete vital sign, and really could benefit from a little bit of a tune-up by our team. So I'm going to start here with Jessica Rogers. How do you approach this athlete, thinking about their history of these recurrent injuries and even the comment on the iron deficiency?
Sure, thank you. So it's really about trying to figure out how we can optimize nutrition. With this one, this is super common in your adolescent athlete. And typically, if they're not eating breakfast, the next time they're eating is, between 10 a.m., 12 p.m., and they never quite catch up in their calorie needs, which starts the day with a deficit. So I talk a little bit about strategies for getting nutrition in easily. And if appetite is an issue in the morning, we talk about drinking our calories, adding in a source of calcium, like from the start in the morning, depending on when they're taking their iron. And in terms of iron optimization, usually recommend taking it first thing in the morning, typically fasted with some vitamin C and away from calcium. So it's a matter of spacing out the iron and the calcium for absorption of both, depending on what time they're getting up. And really thinking about their day and where they have opportunities to take in calories. A lot of times they won't eat breakfast, then they finally have something for lunch, but then avoid eating in the afternoon because they have practice right away, and are consuming all of their calories at dinner when they get home. And so there's a conversation and some education about distributing their calories, protein, calcium, etc. throughout the day, because we only absorb so much in one sitting. And so a lot of it's education around how much they need for the volume of training that they're doing.
Those are all really good points. And again, you got to break the fast and make sure they're getting the frequent meals throughout the day. We also have to make sure that these athletes understand that we're allied with them, and we're not necessarily labeling them as having disordered eating or even an eating disorder, as the female and male athlete triad and relative energy deficiency and sports model reflect that most of these low energy availability or energy deficiency states are unintentional. It doesn't mean that there isn't a role, though, for sports psychology. Dr. Becker, how do you think about the approach for this athlete?
Yeah, I think really we start off with these athletes to really rephrasing that point you just made, Adam, which is saying that, our role is to keep them in their sport. Like we want to help them be as healthy as they can be, both mentally and physically, to stay in sport. We're not trying to create undue limitations on them by labeling them with an eating disorder. But I also like to help folks see that this can be a backdoor way into more complicated eating issues by highlighting that by loss of estrogen or by not getting enough nutrition, the brain starts to function in habitual ways. It starts to become more anxious, more compulsive, and that these are features of dysregulated eating. And so we want to protect them from that. And one of the strategies I often use with these athletes that don't have a clear eating disorder per se, but are having risky eating behaviors and are suffering some consequences nutritionally and physically because of that, is pit their athletic identity against any possible eating disorder, really highlighting that now is the time for peak bone mass accrual. Now is the time, like if you want peak performance, we've got to get you there, like really highlighting that and devaluing eating disorder messages about being thinner, being faster, or about any kind of body image related stuff, devaluing that for hopefully where their brain is at this point, which is really improving performance and staying in their sport.
Yeah, I couldn't agree more. We're really setting the stage for, the whole life for the female athlete, developing, healthy attitudes about food and fuel and recovery and identity. And, ultimately this athlete is coming in though with a second bone injury, and I'm anticipating there might be something more to add. Dr. Graber, how do you bring this home for us? What do we think about in the load management principles and the return to run progression? Can you take us through that for a moment?
Yeah, absolutely. And I think this is one of the most complex cases that we see, and it really highlights such a big need for a multidisciplinary approach to care. Off the bat, like when I see this type of case, like I know that I'm a little bit lower on our priority list in terms of like what's necessary workup wise. Right off the bat, like her needing labs, a DEXA, speaking with nutrition, sports psych, all of that really comes first in my mind. But then, when she does come to see me, like I think thinking about like a gradual progression back just from a load tolerance perspective is really important. Making sure she can tolerate strength training first, then getting to a bit of a plyometric phase, and then getting her to running again. And whether that looks like interval training in the beginning with walk jog intervals and then progressing to continuous, like that might be part of the plan. It depends on how she's progressing and how she's feeling and a lot of other factors. But then when we get to her training overall, like, I want to know if she has a structure in place. When she is training, does she have cycles where she maybe has like a 4-week training plan? Does she have a recovery week built in where she decreases her mileage a little bit? Throughout a given week, do we have days that are more dedicated to longer runs, speed days, easy runs, cross training? Do we have a little bit of strength training incorporated? I think making sure that this type of athlete has some sort of training structure in place is really important. And then taking it a little bit a step further. I mean, I know we've spoken a little bit about like early sports specialization. She's 17. Is the plan for her to continue running long term? If that is something she wants to do long term, it's important to incorporate some other things along the way, whether that's some type of cross training, other types of sports, just so her body has some variability in movement patterns and loading, just contributing to reducing her overall injury risk and her risk of burnout.
So I think you're really hitting a lot of the high points, which is that we understand bone takes up to 6 months to fully recover, that you need cycles of load followed by recovery, that we need to make sure the nutrition and mental health are being optimized. And if all else fails, sometimes we need to move on to surgery. Dr. Waryasz, we described a tibial bone stress injury. This athlete now has had a structured approach to approaching the prehabilitation if this moves on to a surgical approach. But again, maybe you could highlight how we think about the location of this bone injury in the tibia and how you might approach this differently if it's an anterior tibial cortex injury versus posterior medial distal tibia.
Typically, the anterior cortex will sort of, pull towards surgery a little bit quicker because of the concern for it sort of potentially releasing with trauma. But the posterior medial one, we don't typically have to fix. So, and then we would have a nice discussion with her about, knee pain from a tibial nail, or plating, which would be a little prominent with a bigger incision. And so the hope with these is that someday we'll have better biologic treatments with absorbable implants, which we have smaller gauge implants now that we can use for a lot of these, but not anything that's like nail size. So there's some bio glasses that are coming out that would mean it's something that stabilizes the bone, hardens it,
but then doesn't live there forever because as we've all seen, patients that have tibial nails, the interlocks sometimes bother them. They get this anterior knee pain. And so that's the last thing that someone like this needs if they can heal without it, which is always the goal for these.
Yeah, so again, what I hope you take away from all these cases is the value of having a multidisciplinary team approach, understanding some of the sex differences that exist in these sports medicine injuries and nuances in the management, and really the value of taking a team-based approach. I'm really proud to be here at Mass General Brigham and to be working with such esteemed colleagues. And again, build a team. If you're taking care of the female athlete, the athlete's at the center of this team. And taking this more broad perspective is going to lead to the best patient outcomes possible and advancing our translational knowledge on how we can advance research and clinical discoveries to take care of the female athlete more effectively. So those are my concluding remarks. I just thank everyone who's joined this webinar, and I know that everyone on this panel always welcomes referrals or questions, so please feel free to contact us in the future, and we hope this helps you to advance your clinical care of the female athlete. Thank you.